Hello everyone, I'm Dr. Ushna Naqvi, the founder of AMC Smart Prep and Derm online platform. These are the two platforms which are providing the preparatory courses for your dermatology as well as AMC theory sessions. So if you are a dermatologist which is planning to move towards AMC pathway, or if you are fresh graduate who is opting for the AMC pathway, then this channel is perfect for you. This is the code you can scan to join the WhatsApp group to be updated with updated guidelines on all the important videos or recommendations regarding your AMC platform. So, just without wasting the time, we will jump towards our topic, which is Necrobiosis Lipoidica. This is a very important topic for the exam, for both exams, dermatology as well as AMC exam. Relatively uncommon, relatively rare, but exams loves to ask a necrobiosis lipoidica. You should have an idea about the diagnosis, how to rule out the differential diagnosis, how you are going to diagnose by looking at the picture. The picture is also very important. And for dermatology candidates, the histology is also very important for you guys. So this is a very important topic. You should pay attention till the end of the lecture. What is necrobiosis lipoidica? First of all, the definition: it is a granulomatous disorder. So, what do you mean by granuloma? Whenever you have a collection of cells which is forming a very compact structures in your skin, this is known as granuloma. So, we have many cells in the necrobiosis lipoidica which have lymphocytes, histiocytes, and many other cells. Plasma cells is also a very important component of your necrobiosis lipoidica. Apart from this component, necrobiosis, that means breakdown, degeneration. So you are going to have collagen degeneration, you are going to have granuloma, and one very important component, which is lipid deposition. Lipid deposition is a very hallmark feature of your necrobiosis lipoidica. Now, earlier times we used to denote the term necrobiosis lipoidica diabeticorum specifically because it is very common in your diabetic patients. Most common association is the diabetes. But this term is relatively rather misnomer kind of thing because all the patients of necrobiosis lipoidica are not associated with the diabetes. Yeah, majority is, but sometimes you find the cases which are not diabetic patients, okay? So you cannot just say necrobiosis diabeticorum. The general term necrobiosis lipoidica is recommended. It mostly affects your shins, and how the patient is going to present to you, that is mostly asymptomatic plaques. You know what is plaque? Plaque is more than 1 centimeter raised area onto your skin. That is plaque. Why we are more feared for the diagnosis of necrobiosis lipoidica? Because there are very high chances of development of cancers. If the patient is having necrobiosis lipoidica, then there may be risk of development of squamous cell carcinoma. That is your particular concern. So there is very particular description of necrobiosis lipoidica that your pretibial area is going to have yellow brownish plaque with your atrophy. Atrophy means thinning of the skin. So you are going to have atrophy or the telangiectasia onto your skin surface. You can easily identify this is a necrobiosis lipoidica by just looking at the picture. I have attached a picture as well. This is a very you can say a pathognomic plaque of your necrobiosis lipoidica. Typical location is on chin. You can see this is atrophic plaque. Skin is thinned out. You have prominent capillaries, which is telangiectasia, and you are going to have this hyperpigmented, beautiful border, violaceous kind of border in a surrounding structure, and the plaque is somehow yellowish appearance. So yellowish, you can compare that there is something lipid deposition which is going to play a role in the pathology of your necrobiosis lipoidica. That's why on your histology you are going to have lipid droplets. Okay, so this is a very important plaque. You need to remember this picture as such, as a visual memory for your exam. So typical location is anterior tibia. As you can see, pretibial area, there is going to be well demarcated plaque, yellowish brown plaque. Atrophy is a very important component. Wrinkles can be there, and telangiectasia can be there. Border has a very important characteristic. You are going to have raised erythematous and telangiectatic indurated border. And the patient is mostly asymptomatic, but the thing is that this is a chronic condition. That's why we are more concerned. Whenever a thing is chronic, there is a chances of development of any complications like squamous cell carcinoma. So we have many variants of necrobiosis lipoidica. That was a very typical variant which we talked about. The dry looking, shiny looking, smooth looking, yellowish appearance of on your shin. But sometimes the same plaque can undergo ulceration as well. So you can have ulcerative necrobiotic plaque as well, but it will retain all the characteristics. The border is hyperpigmented, border is raised, border is erythematous. you are going to have some telangiectasia on your surface, and the center is having ulceration. So this is ulcerative necrobiosis lipoidica. You can have bullous also, generalized also, and perforating also, but these are very rare. You just think about that particular common presentation first. This is very uncommon presentation, which is basically ulceration, or you can have squamous cell carcinoma. So these are all the complications of your necrobiosis lipoidica. The next most important thing is histology. For your dermatology candidates, the histology is very important. For AMC, histology is not that much important. They can give you one or two clue, but if you just ignore the histology, that would be okay. So you can skip these part of your histology. So histology, it's very important to remember that necrobiosis, you have degenerated collagen. And for necrobiosis lipoidica, the main component is the necrobiosis. So you are going to have degenerated collagen in whole of the layer of the skin. Deeper depth of the skin is going to have degenerated collagen. This is seen in the pinkish, beautiful slides. And in between the slides, you have this blue color of cells. These are infiltrates. These are lymphocytes, histiocytes, plasma cells that are forming granuloma. So if you just compare this picture, you can easily identify your histology just like a beautiful tempting kind of cake picture. You are beautiful layers of your cake, frosting, chocolate, and the cake sponge. That's how the necrobiosis lipoidica histology actually presents. In the superficial part, you are going to have atrophic epidermis. Just below the epidermis, you are going to have so beautifully arranged palisading granuloma most of the time. That is a very typical histology of your necrobiosis lipoidica. And then you are going to have this necrobiotic dead collagen, degenerated collagen, which is a very important part of your histology. And then in between your collagen and all these things, you are going to have scattered cells in the form of plasma cells, in the form of giant cells. You have abundant blood vessels, and sometimes, not sometimes, mostly you have mucin as well. But remember, a very close differential is granuloma annulare. Granuloma annulare has more component of mucin as compared to necrobiosis lipoidica. Our necrobiosis lipoidica has a very less amount of mucin as compared to granuloma annulare. So these are very typical slide, typical features of your necrobiosis lipoidica, that your necrobiosis is extending on whole of the depth of your dermis and invading into your subcut fat. And you're going to have so many, you can say, empty cells, which are basically your cholesterol clefts, or you can call it as lipid droplets. Okay, so these are all the features of your necrobiosis lipoidica histology. After histology, if you have made the diagnosis of necrobiosis lipoidica so clearly, then what are the differentials you have to look for? Because there are many disorders which can present as the granulomatous disorder. You have granuloma annulare, like I have told you. It has so much mucin in the granuloma annulare. You can have diabetic dermopathy. You can have sarcoid. Sarcoid has non-caseating granuloma. There's no caseation in the sarcoid. There's no mucin in the sarcoid. So you will easily identify. You can have pretibial myxedema, similar kind of appearance. So histology is very important, site is very important, typical location is very important, and the clue which we have looked for, cholesterol clefts and the necrobiosis and palisading granuloma, these are the things that will make you clear that this is a patient of necrobiosis lipoidica, not any other condition. Then if you have made the diagnosis clearly, then what is the treatment options? First of all, diabetes is a very directly association with your necrobiosis lipoidica. So first thing that should be very clear, you should just control your diabetes. If you are optimizing your diabetes glycemic control, that is very important for the control of your any you can say skin manifestation of diabetes itself. So general measures include your diabetic control, it include your ulcer control, basic hygiene, everything. But if we talk about specifically that what is the treatment of necrobiosis lipoidica for your exam, specifically I'm talking about AMC exam, that they love to ask initial management, best management, confirmatory management, this kind of thing. So first of all, they have 2-3 questions. You are clearly made the diagnosis, you are able to identify the picture. The third thing is that they will ask how you are going to diagnose the condition. Okay, so this is a clinical diagnosis. If you are not sure clinically, then you go for biopsy. Biopsy means histopathology, whatever the changes we have looked for, that is visible on biopsy. So biopsy is the confirmatory test you are looking for the necrobiosis lipoidica. Then comes the treatment part. So treatment, what is the initial management of your necrobiosis lipoidica? Initially, it's always steroids. Okay, You are starting from the topical steroid. If there is a one localized lesion, you can go for the intralesional steroid as well. After topical steroid, you can go for topical tacrolimus, and if the patient is not responding, in some cases there is puva therapy benefit also. After giving all the trials of topical, intralesional, phototherapy, then your systemic therapy comes. So you have options of, if the patient is having refractory disease not responding to your topical one, you have option of methotrexate, mycophenolate, or anti-TNF. And the last resort is going to be your surgical excision. Mostly we don't go for the surgical excision. These are the treatment which are enough for your necrobiosis lipoidica patient. So these are the steps, or you can say these are kind of take home message, that how you are going to approach the patient of necrobiosis lipoidica. The very important thing is it has a very strong association with the diabetes, so never ignore diabetes when you are talking about the necrobiosis lipoidica patients. Then the typical description that is going to help you to make the diagnosis very clearly, that you are going to have pretibial area involvement, you are going to have very beautiful yellow vexy, they use the word vexy. So vexy, vex like appearance, yellow vexy, and the atrophic plaques with the telangiectasia. In histology, you are going to have palisading granuloma with the necrobiosis and cholesterol clefts, and you are feared of having complication, which is basically your ulceration, which can be your secondary infection, and which can be your squamous cell carcinoma. So all these you should take into consideration when you are dealing with a patient of necrobiosis lipoidica. There is no definitive treatment. You have to aim for the diabetes control and then symptomatic management. Whatever the lesion is, you have to manage accordingly. So this is basically your necrobiosis lipoidica. We will practice some questions side by side, that which condition is strongly associated with necrobiosis lipoidica. Now you are very sure that this is your diabetes mellitus. Diabetes is associated with your necrobiosis lipoidica. Then which of the following is the most common site of necrobiosis lipoidica? Then again, we have just make the thing very clearly that anterior tibial area is the most important predisposed site for the development of necrobiosis lipoidica. Then, what is the histopathology of necrobiosis lipoidica? All the things except. Such kind of question can also come in your exam. So you should know very particular things regarding any topic, that these are the conditions which are included in the topic and this is not. So you have palisading granuloma, you have necrobiosis, you have cholesterol cleft, but you do not have epidermal acanthosis. Acanthosis mean you can say thickening of your epidermis, thickening of your stratum spinosum particularly. So you do not have thickening, you have atrophy rather. So this is not the right thing. Okay, you are going to have atrophy of your epidermis in your necrobiosis lipoidica. And the long standing patient of necrobiosis lipoidica may lead to, so they have confused you by giving all the cancer options: BCC, SCC, melanoma, Kaposi sarcoma. These are all your skin cancers, but we know very clearly that necrobiosis lipoidica is most likely associated with squamous cell carcinoma rather than BCC, rather than melanoma. This is most likely concerned with the squamous cell carcinoma. So this is all about your necrobiosis lipoidica. They have given this picture exactly in the exam for AMC recalls. I don't remember exact month, but you, if keep on doing the recalls, you will come to this kind of question, that this picture was in exam once. So you should have a visual memory of this picture as such. This is a very typical picture, and sometimes this is a very typical picture of your necrobiosis lipoidica. Maybe ulcer is not present, but this picture is a very favorite picture for your exam. So any lesion, any plaque which has atrophic surface, which have vexy appearance, telangiectatic surface is present on your chin, think of necrobiosis lipoidica until proven otherwise. Specifically, if the patient is having diabetes as well, then your question is locked. This is necrobiosis lipoidica, nothing else. So if you want to join the AMC preparatory course, or you want to join dermatology course as well, then these are the links for the AMC prep groups, which is basically Telegram group or the WhatsApp group. You can maybe you are not able to click the link because this is in the video, but I will add these links into the description box as well. So you can have access to the Telegram group, you can have access to the WhatsApp group, and this is the code you can scan to join the WhatsApp group. And if any query, you can comment in the comment section and I will reply according to that query. Thank you so much.